Hi friends, I am Dr. B.V. Rao of Usha Clinic and founder of the websites qmedicaldoubts.blogspot.com and rakhavamedicaldoubts.com. Through these videos, I am providing the basic knowledge about the commonly occurring diseases, treatment, and surgery details when necessary for the for the general knowledge to general people and for reference to medicals. Today, I am going to discuss about the renal failure types and management. The renal failure is otherwise called the uremia. The retention of abnormal amounts of urea in the blood in renal disorders was among the early discoveries resulting from the application of biochemical methods to the elucidation of the disease, and the symptoms of chronic renal failure were long attributed to it. The recent knowledge of renal physiology has shown that as the renal function becomes impaired, other complex biochemical changes occur, and that those are probably more responsible for the clinical features of uremia than the elevation of blood urea. The resulting changes are disturbance in hydrogen ion concentration, abnormalities in water and electrolyte balance, and accumulation of many products of metabolism. Renal failure is accompanied in majority of cases by arterial hypertension, and this fact complicates the clinical picture. Classification: the renal function may be impaired by diseases of the renal parenchyma, renal uremia, by extrarenal disorders as acute circulatory failure or pre-renal uremia, or as a result of conditions in which there is obstruction to the outflow of urine, post-renal uremia. Renal uremia. Impairment of renal function results in renal failure, may be acute, chronic, and of varying degree of severity. Acute renal failure. It may be due to the various conditions as acute proliferative glomerulonephritis, acute bilateral pyelonephritis, malignant hypertension, polyarteritis, systemic lupus erythematosus, and eclampsia with renal involvement. Thrombocytopenic microangiopathy or primary vascular coagulation affecting the glomeruli are affected. Acute renal failure also may be due to the acute circulatory failure leading to sudden reduction in renal blood flow. This reduces the capacity of the kidney to perform the functions, resulting in pre-renal uremia due to water and salt depletion, shock, hemorrhage, etc. With the correct treatment, this uremia is reversible and the prognosis generally good. In some cases, pre-renal uremia and renal ischemia may be so severe and prolonged and produce damage to the renal parenchyma. When this affects only tubules, the condition is called acute tubular necrosis. Very rarely, in complicated pregnancy with retroplacental hemorrhage, the whole of the large part of the renal cortex is involved. The glomeruli and the tubules become necrotic, and the condition is called the renal critical necrosis. Chronic renal failure. This condition occurs as a result of diseases which destroy the renal tissues more slowly, as in progressive proliferative glomerulonephritis, membranous glomerulonephritis, or chronic glomerulonephritis. Chronic pyelonephritis, or polycystic disease of the kidney, hypertension, diabetic nephropathy, amyloid infiltration, tuberculosis, and the conditions causing hypercalcemia. Anatomically, means the site of the lesion responsible divided into four types as renal uremia due to the disease in the kidney, pre-renal uremia due to pre-renal disease, acute renal failure due to acute tubal necrosis, renal failure as a result of the obstruction of the renal tract resulting in impairment of renal function, post-renal uremia, renal failure due to disease of the kidney, renal uremia. The clinical features and treatment are those of the glomerulonephritis, and those of the other chronic kidney diseases are similar, but also those of the underlying disease. Renal failure due to pre-renal disorders, pre-renal uremia. The function of kidney is maintenance of adequate renal circulation. The renal share of cardiac output usually about 25% at rest. If the cardiac output falls, the renal blood flow is disproportionately reduced and oliguria results. Regional vasoconstriction is a means by which the blood pressure may be maintained in the face of oliguria, and the success of this mechanism may deprive the kidney of a large part of their blood supply. The urine formed is less in volume, and the concentration of urea in the blood gradually rises. The common causes of pre-renal uremia are loss of blood, loss of plasma as in burns and crush injuries, loss of fluid and salt as in vomiting, diarrhea, diabetic ketoacidosis, Addison's disease, and heat stroke by sweat. General anesthesia and operations causing hypotension, blood loss, leading to low renal blood flow and renal failure in those whose blood volume is previously balanced. Infections like that of the Escherichia coli may produce shock and reduce renal blood flow. Acute cardiac failure due to myocardial infarction. Treatment. The treatment includes the appropriate fluids intravenously, like in diabetic ketoacidosis, Addison's disease, infection. Prompt and effective replacement of blood, water and salt is essential. In many cases, vigorous treatment in the early stages prevents the occurrence significant degree of renal failure. If oliguria and anuria persists in spite of a return of blood pressure to normal, acute tubular necrosis is assumed and treated accordingly. Acute renal failure due to tubular necrosis. It is a disease affecting both kidneys with the symptoms anuria or oliguria with urine of low specific gravity and rapidly developing uremia. Acute tubular necrosis occurs as a complication of marked hypotension, arteriolar constriction and severe water and salt depletion. Clinical features. Oliguric phase. The urine volume is reduced to 200 to 500 ml in 24 hours. The urine contains protein caches and red and white blood cells. Specific gravity in the beginning is 1.010 and persists for several days. In the beginning, the patient is comfortable, but later the features of uremia develop. There is anorexia, nausea, vomiting, apathy, mental confusion, muscular twitching, fits, drowsiness, coma, and bleeding episodes occur. Pulmonary edema due to injurious administration of excess of fluids. Potassium intoxication due to the rise of concentration of plasma potassium, which is especially likely if there is hemolysis or massive soft tissue damage. The occurrence of systemic infection to which the patient is susceptible, and the uremia itself. The oliguric phase and anuria may last for 1 to 3 weeks. Diuretic phase. If the patient does not succumb, the daily volume of urine increases and may reach several liters. This stage coincides with the healing of renal tubules, reduction of intrarenal tension, and resolution of intratubular casts and intraglomerular coagulation. In this stage, there is a loss of sodium and water, and sometimes flaccid paralysis due to loss of potassium occurs due to absence of treatment. The concentration of blood urea ceases to rise and then gradually falls. Recovery of renal function then takes place slowly over a period of 6 months. Treatment. Cause. With a view to prevent or minimize the renal lesion, the underlying cause should be treated urgently and the appropriate solutions administered to replenish deficits. Oliguric phase. Ischemic renal lesions are reversible provided the patient is kept alive during the oliguric phase. Treatment is therefore designed to minimize the need for renal function until healing occurs, and this can be achieved by simple dietary restrictions. Water and electrolyte balance. This is maintained by replacing the amount of loss through the skin and lungs equals to be 600 ml of water per day, and by giving no electrolytes since none are from the body. In case of patients with fever, extra water is required to replace water lost by perspiration, and a small supplement equal to the loss of urine passed daily should be added. In case of diarrhea and vomiting, additional amounts of fluid is required. Protein and calories. Dietary protein is restricted to about 20 grams per day, and attempts are made to suppress endogenous protein catabolism to a minimum by giving as many calories as possible as fat and carbohydrate. For this purpose, a diet restricted in protein and electrolyte content may be supplemented by a liquid glucose preparation, high cal. In case of vomiting, carbohydrate should be given in the form of 10% fructose IV. In case of a mild case with short duration, this treatment prevents the rise of blood urea, and accumulation of potassium from protein catabolism is also sufficient to produce serious consequences. If plasma potassium occurs, the use of sodium or calcium changed resin which removes potassium from the body. Giving 20 units of soluble insulin subcutaneously and an intravenous infusion of 20 grams of glucose, controlling acidosis by intravenous administration of isotonic bicarbonate is used. Hemodialysis. In some patients with severe infection and massive tissue damage or blood loculated in tissue spaces, the rate of rise of blood urea and potassium may rise rapidly, and life may be threatened from acute renal failure. In such case, the patient is shifted to a center equipped with the means of extracorporeal dialysis, artificial kidney. Daily hemodialysis may be required over several weeks before the renal function returns. When this policy is adopted, it is possible to be liberal regarding the intake of protein, fluid and calorie. This is desirable from the point of encouraging repair of damaged or diseased tissue, and is rendered possible by the daily correction of the composition of the blood and volume of body fluids achieved by the artificial kidney. Peritoneal dialysis. It is an alternative to the hemodialysis, but it is useful in the treatment of small children. It is prolonged and uncomfortable, sometimes painful procedure, and usually with complications. That's all about the renal failure, and in the next video I will discuss about some other disease. Thank you.